பெரிய இஷ்யூ சால்வ் பண்ணிருக்கீங்க. வெரி குட்.
தேங்க்யூ சார். தேங்க்யூ சார். தேங்க்ஸ் ஃபார்
சார் உங்க இது எக்கோ அடிக்குது சார்.
வெரி வெரி டிப்ளமேட்டிக்
சார்.
சார்
டிப்ளமேட்டிக்.
இதோ
சீனிவாசன் சார், சார் உங்க இது எக்கோ அடிக்குது சார்.
எந்திலியா?
ஆமாங்க சார், உங்களுக்கு எக்கோ வருது சார்.
ஏன் எதனால இருக்கும்?
இல்ல இப்ப கரெக்ட்டா
வருது சார்.
இப்ப கரெக்ட்டா இருக்கு சார்.
இருக்கா? ஓகே.
பேண்ட்விட்த் கொஞ்சம் லோவா இருக்கு. சோ வீடியோ மட்டும் எடுத்துடலாம் சார். ஐ திங்க் ஆடியோ ஓகேவா இருக்கும்னு நினைக்கிறேன்.
ஓகே.
ஸ்டார்ட் பண்ணிடலாமா சார்?
பண்ணலாம் சார்.
யா. Okay,
good evening everyone. It gives me great pleasure to start the 105th postgraduate clinics of IAP TNSC. Let us start the day's program with the pediatrician's prayer by our academic coordinator, Dr. Murugesh Lakshman.
எங்களுக்கு முழுமையான குட் ஈவினிங். எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும் நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர்தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய நிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும், நல்லவற்றை உள்வாங்கவும், மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள்.
Thank you, sir. Thank you very much, sir. It gives me great pleasure to call upon our president, Dr. Balashikar sir, to say a few words and start the program for today. Over to Balashikar sir.
Good evening, everyone. Good evening, office bearers, as well as the teachers, students, and the participants of this 105th PG clinics. And in the series of short cases in pediatrics, in the heading under nutrition, we have got a stalwart among us, Dr. Srinivasan sir, former registrar of ICH, who is a mentor of so many people, so many pediatricians all over India. And I welcome you, sir, for this forum. I hope you will give a fantastic class today. Everyone will remember forever. And I am very happy that my close associate Sivakumar for being the mentor today, and his college postgraduates from Sivaganga are the one who are participating and presenting cases. And I'm very happy to invite Dr. Sivanandam from KMCH, an expert in this field, to enlighten us on the topic nutrition. We all know nutrition is one of the cornerstones in pediatrics. Nutrition, immunization, growth and development, this is what pediatrics are almost all about. So nutrition is one of the important aspects. And there are so many small nuances in nutrition. Apart from just some broad things like marasmus, kwashiorkor, and all those things. Okay, but those terminologies are gone. Now they are going for Z-score and all those things. Okay, I think there's a lot more to learn in nutrition, even for an experienced pediatrician. This class will throw light on so many aspects in nutrition, and we'll all have a good learning time tonight. Thank you very much for the opportunity.
Thank you, sir. Thank you very much, sir. Over to Dr. Murugesh Lakshman, our academic coordinator, to conduct the proceedings. Murugesh Lakshman, sir.
I think we'll start with the first case. Santosh.
Sir. Good evening, sir. Good evening. Good evening, Balasam, sir. Good evening, Srinivasan, sir. Good evening, Murugesh.
Sir, before we start, can we ask
sir.
inputs from Srinivasan, sir?
Sir?
Or go straight to the case, sir.
Thank you.
Srinivas sir, ஆரம்பிங்க. நீங்க தான் ஆரம்பிங்க.
Okay,
சார் நீங்க ஆரம்பிங்க சார். ஒரு ரெண்டு வார்த்தையோட ஆரம்பிங்க.
the postgraduates because present everybody wants to know.
Sir, கேட்கல sir. Something is wrong.
இல்ல நீங்க can you hear me now?
Yes, sir.
கொஞ்சம் பரவாயில்ல சார். முதல்ல கேட்கல சார். சார் இப்ப கேட்கல சார்.
Scenario it is also கேட்கலையா? ஒருவேளை என்னுடைய இயர்பாட்ஸ் ஏதாவது ப்ராப்ளமான்னு தெரியும்.
உங்க இயர்பாட்ஸ்னா உங்களுக்கு தான் சார் கேட்க கூடாது, எங்களுக்கு கேட்கணுமே. மைக்ல தான் ப்ராப்ளம். நெட்வொர்க் வந்து கொஞ்சம் கம்மியா இருக்கும் சார்.
Sir,
can you hear me sir now? Can you hear me now?
Yes sir.
Yeah, I think my earbud is the problem. I feel nutrition is very, very important for the PGs because all medical colleges, there was no nutrition department so far. So only those people who are trained or who are interested in nutrition are teaching the PGs. So a nutrition class in IAP is, I think it's a welcome in nature. More importantly, present trend is to learn intensive pediatric care. I feel nutrition also is an important role in intensive pediatric care. 45% to 50% of the PICU patients will come around nicely if you start nutrition on day one of life, even in the pediatric intensive care unit. So that is the importance of nutrition. With that small introduction, I request the PG to present.
Santosh, screen share பண்ணுங்க.
Yes. Good evening, sir.
Yeah, start doing.
A 1 year, 6 month old male child, a firstborn out of non-consanguineous marriage, brought by his mother, whose reliability is good, presented with chief complaints of fever and cough for the past 2 weeks. The child was apparently normal 2 weeks back, after which he had fever for 2 weeks. This intermittent nature, not associated with chills and rigor, not associated with rash or scar, relieved on taking medications. Cough for the past 2 weeks, wet cough, no postural diurnal variation, not associated with breathlessness, no history of aspiration, history of letharginess for the past 2 days.
1 minute for interruption. Whenever you start presenting a nutrition case to the examiner, the examiner expects that you are going to present a malnutrition. But when you start presenting with fever and cough, examiner will get diverted towards, are you talking about some respiratory case or some other thing? So what I want to tell you that even though these cases are coming only respiratory or diarrhea or something, you must not include in the complaint that the mother was also complaining that the baby is not eating. That will be there in the complaint. You are presenting to the examiner. Suppose you are presenting other cases, it's fine.
Sure, sir.
Sir, you started with
Can
apparently
you-
normal. Yes, sir, I can able to hear. You started with a child who is apparently normal. This child is apparently normal child, or a child is like a previously unwell child? Sir, I'm audible, sir?
Yeah, you are audible.
Sir,
டாக்டர் யமுனா மியூட் பண்ணுங்க. ஹலோ,
அது ஒரு மீட்டிங்ல இருக்கேன். இல்ல என்ன சொல்லு. சரி நான் கூப்பிடுறேன். நான் 9:30 முடிச்சு கூப்பிடுறேன். இல்ல 7 to 8:30 தான் போகும்.
Continue பண்ணுங்கப்பா.
Yes, sir. With the history of letharginess for the past 2 days, you think history of decreased food intake for the past 2 days, associated with history of not gaining adequate weight after 6 months of age. No history of ear pain, no history of ear discharge, no history of vomiting or abdominal distension, no history of loose stools or constipation, no history of passing worms in the stools or passing sticky bulky stools, no history of dysuria, no history of joint swelling, no history of bleeding gums or easy bruisability of the skin, no history of visual disturbances, no history of alopecia, no history of pigmentation of skin, no history of swelling of legs or dependent edema, no history of seizures, altered sensorium, loss of consciousness, or abnormal movements. Past history of similar illness in the past 3 months back.
No, these were relevance of saying history, normal movement and other things in these cases. What's relevance? No history of seizure, altered sensorium, loss of consciousness. We want talking about case. What is the relevance of this history?
Sir, in respiratory illness, maybe due to hypoxia, or in malnutrition due to hypoglycemia, the child will be altered sensorium.
You are not breathlessness. You must talk about that I'm expecting some electrical disturbances, something like that. Severe acute child more prone to go for hyponatremia. Sometimes they may go for hypokalemia. They may go for hypoglycemia. So these are all the reasons for the child to have altered sensorium or conversion. So whenever you talk about seizure in child, always think of this, right?
கேட்கல சார். சார் நீ பேசுறது சார்.
சார் எக்கோ வருதா?
ஆமா சார், ரொம்ப வருது சார்.
நான் ஃபோன் சேஞ்ச் பண்ணி யூ கேரி ஐ வில் சேஞ்ச் மை ஃபோன்.
எஸ் சார், எஸ் சார். ஓகே.
Past history.
Go back. You said so many negative histories, no? Just give explanation for those negative histories.
Ear pain or ear discharge are seen in middle ear infections, which is or vomiting or abdominal distension, since the child is not gaining adequate weight.
Okay.
And loose stools are constipation, worm infestations, sticky stools to ask history about steatoria.
So which respiratory infection you will get in sticky stool with associated with sticky stool? Bulky stools, foul smelling bulky stools. Which condition, with which respiratory condition you will get this kind of stool? Like cystic fibrosis, no?
Cystic fibrosis.
Yeah, cystic fibrosis with respiratory system involvement and the G8 involvement, you will get sticky bulky stools, sticky bulky stools.
Yes, sir.
Okay, continue.
So past history.
Yeah, past history, you can continue.
History of similar illness in the past 3 months back, for which the child was hospitalized for a lower respiratory tract infection and undernutrition in a hospital, treated with IV antibiotics and advice regarding nutritional supplements. Child was not on any chronic medications, not a known case of CST, seizures, bleeding disorders, or any other congenital anomalies. No history of fever with rash or chronic cough, vomiting, or diarrhea in the past. No history of contact with pulmonary tuberculosis.
So what do you mean by no history of fever with rash?
Sir, since the child is malnourished, the child may have measles or...
Yeah, good. Measles infection can lead to malnutrition and then leading to the SAM like the picture. Okay, continue. And chronic cough?
Sir, tuberculosis.
Yeah, good. And chronic diarrhea also.
I will ask you one thing. What is the diagnosis of this case?
Sir?
Hello?
Sir?
What is the diagnosis?
Severe acute malnutrition with pneumonia.
So from your present illness, past illness, can you come to a conclusion that anyway you are near to the diagnosis?
Sir, in history, the mother said the child was not gaining adequate weight for the past 6 months, from 6 months of age, sir.
Explain the word adequate weight. How can a mother says adequate weight gain? Whether she is knowledgeable or
Sir,
how she says also?
Sir, the mother's sister's sons were her own son was not on comparing with the sister's child.
Very good. Always mother will compare with the other children and they say whether my child is gaining weight or not. That is the common thing you always see in this child. Okay,
Yes.
right. And you said last time 3 months back baby got admitted for lower respiratory tract infection with undernutrition.
Yes, sir.
Can you explain that? What is that undernutrition?
Sir, so weight for age is less than -3 standard deviation.
Less than?
-3 standard deviation.
That will not come under undernutrition. So undernutrition nowadays those terminologies are not much used.
Okay.
It is either a severe acute malnutrition or moderate acute malnutrition, something like that only. So when I say undernutrition, you cannot say -3 standard deviation. Okay. So always try to avoid those kind of words in the history examination. You can say child was admitted for lower respiratory tract infection and also the child did not gain much weight during that time according to the mother. You just finish like that.
Okay.
But don't give any diagnosis in the history because undernutrition is an history diagnosis. Always
Yes,
avoid to the examiners. Okay. Right.
Yes, sir.
Go to the antenatal illness. Right.
Antenatal history: 21 years old primary mother whose educational status was up to 10th grade, booked and immunized in a PHC. Pregnancy confirmed by UPT and had 4 antenatal visits in a PHC. Mother had taken iron and folic acid regularly. No history of bleeding, fever with rash, arthralgia, or post-auricular lymphadenopathy during the antenatal period. No history of drug or radiation exposure or substance abuse during pregnancy. Quickening felt at 5th month of gestation. Adequate fetal movements. Mother was underweight and was anemic during antenatal period, for which she had 5 doses of iron sucrose transfusion in the PHC and no other comorbidities.
What was the weight gain during the antenatal pregnancy? Whether mother can be able to tell that?
Sir, mother said during her antenatal visits, she was underweight only, sir. She doesn't
No. Every mother. He was at primary health center and was given some blood transfusion, something. That must be showing whether she has gained adequate weight gain or not. So, what do you mean by adequate weight gain during the AN period? Can you tell me?
Sir, for normal weight gain, the mother should gain 9 to 12 kgs from the pre-pregnancy weight.
So during the AN period, any mother who is around 50 kg or something, they must gain a weight of around 10 to 12 kg, something like that. Suppose the mother is got obese, then the weight should also more should be that. So you should also say, sir, whether the mother had how much of weight gain happened during the antenatal period. And you said that she had blood transfusion, right?
Iron sucrose transfusion.
Okay, what is the government policy in treating anemia? What regarding the tablets, regarding the iron dextrose, regarding the blood transfusion? What is the government policy?
So in first trimester.
No. What is the government policy? What is the hemoglobin level? What is the management they do?
So less than 11 is termed as anemia. Mild, moderate, severe.
It is based on the number, no, not based on the mild, moderate, severe. Based on the number, based on hemoglobin.
8 to 11. Hemoglobin level 8 to 11. 4 to 7 and less than 4.
No, I think it is not correct. Usually above 9, they always go for iron tablets. 7 to 9, they go for iron dextrose, and anything below 7, they go for blood transfusion. That is a simple way of doing. No range should be there.
Yes,
because the VHN are practicing, seeing all these AN cases, no? There should not be any range. It is like that. More than 9, I go for tablet. 7 to 9, I go for iron sucrose. Below 7, I go for blood transfusion. Okay? That means this mother had blood transfusion. That must mean our hemoglobin must be less than 7, right?
Yes, sir.
Okay, right.
Natal history: a preterm baby delivered at 35 weeks of gestation due to PPROM by normal vaginal delivery at Karaikudu GH. Baby was low birth weight and appropriate for gestation age. With birth weight of
What is the reason for prematurity here? What is the reason for prematurity here? It's a preterm baby. What is the reason?
So mother had PPROM.
That's why there is premature rupture of membrane. Why? What could be the reason? Is it due to infection? What could be the reason for PPROM in this mother? Anemia per se, no? Anemia. If you examine the placenta of these, you need not search for any cause for premature rupture of membrane in these cases. She had blood transfusion also, no? So severe anemic mother can go for low birth weight or SGA babies with the PROM also, right? Okay.
Yes, sir. With birth weight of 2 kg, baby cried immediately after birth and referred to Government Semi Medical College and admitted in for preterm care and low birth weight and respiratory distress. Baby was on oxygen support using nasal prongs for the first 2 days of life, then weaned to room air on IV antibiotics for 7 days of life. Baby started on EBM feeds from day 2 of life and on direct breastfeeding from day 3 of life. No history of prelactal feeds or no feeding difficulties. Baby discharged after 7 days of NICU admission.
Okay. Is the baby vulnerable to become severe acute malnourished child? Whether the baby is vulnerable?
Yes, sir.
In what way?
So preterm.
In other ways, I will put a simple question. When do you diagnose severe acute malnutrition? What is the age group you diagnose severe acute malnutrition?
6 months.
No, the new WHO guideline has changed. The diagnosis of SSAM can be done even before 6 months.
Child's length more than 45 centimeter.
49 centimeter. The length of the child is more than 49 centimeter. With weight for height less than -3 standard deviation, you can make a diagnosis. So why the WHO has come to this conclusion? Why SAM can be diagnosed even before 6 months? What is the reason? Generally, textbooks say 6 months to 5 years. Then now you say even before 6 months. What is the reason? The reason is SAM, which occurred after 6 months, has got less mortality compared to the SAM, which occurs even before 6 months. So to diagnose a SAM before 6 months, the child should be more than 49 centimeter. Why that 49 centimeter? Why the deadline? Why they put 49 centimeter WHO? Why? Because they want to avoid asymmetrical and symmetrical IUGR. Symmetrical IUGR, you cannot do anything. It may be due to genetic problem, maybe due to chromosomal problem, maybe due to viral infections also. But asymmetrical IUGR is most probably due to nutrition. That's why symmetrical IUGR will never touch 50 centimeter. They will be very short. But asymmetrical IUGR, the length will be more, but the weight will be less. That's why the WHO has put the time, that's 49 centimeter. That means you are going to deal only with the asymmetrical IUGR, not symmetrical IUGR. Okay?
Yes, sir.
Okay, right. So that means this child is more vulnerable. In fact, one of the study done in Aligarh, and in fact, I have done a study in ICH diagnosing SAM before 6 months. So what I did, 100 children before 6 months, I took it for a SAM criteria. We are able to diagnose 100 children. There are 4 identifiable causes for this 100 children. Number 1 is the child by birth is either preterm or low birth weight baby. Number 2 is many children, SAM before 6 months had some congenital anomalies. Number 3 is many children before 6 months, due to some reason, maybe immunodeficiency or something, had recurrent infections. Number 4, what we thought, a faulty feeding technique from the mother. A child is born with 3 kg, but still comes at 6 months with 4 kg, faulty feed. So these are all the 4 reasons child can become severe acute malnourishment even before 6 months. It may be due to recurrent infection, maybe due to congenital anomalies, maybe due to prematurity or SGR, or maybe due to faulty feeding technique. So in Aligarh study, they have found 90% of the thing are due to faulty feeding technique. But in ICH study, what we have done, everything was 25%, 25%. So the study differs also. That means you should have an high index of suspicion. Whenever you have a ELBW or VLBW baby or a LBW baby, they are going to be the future severe acute malnourished child. What is the prevalence of SAM in India? Prevalence. Prevalence, what? 6.3% at present. 6.3. Every 100 children, 6 to 7 children are becoming SAM now. Okay? Right. Go on.
Postnatal history. Child was exclusively breastfed up to 6 months of age and continued breastfeeding up to 1 year of age. Complementary feeding was started from 6 months of age and no proper weaning practices followed. Immunization history. Birth dose vaccination was given. BCG scar present.
Can you add one more history? Can you add one more history? Since you told that it is an preterm AGA baby with 2 kg, you said exclusively breastfeeding. Whether there is adequate weight gain in the first 6 months, that history should be added. Because we want to make a diagnosis whether the child has gone for SAM before 6 months itself or after 6 months. That should be there. Even though we are examining now only, you should ask the mother whether when the child was breastfeeding, is there any adequate weight gain? Are you happy with the weight gain? Whether the child attained weight gain like any other children. That history also should be added during the feeding history, right?
Yes, sir.
Okay.
Partially immunized child. Last vaccination was given at 105th day of life, and no further vaccination was given due to poor weight gain and recurrent illnesses. Family history. Father was
measles vaccine was not given, right?
Yes, sir, not given, sir.
The most important measles vaccine. Anything has been missed by 6 months? At 6 months? Any other? Apart from the 3 vaccine, at 6 months, any other thing you want to give?
Pneumococcal vaccine.
What is the schedule for 6 months?
Sir?
Vitamin A. Vitamin A.
Yes, sir, vitamin A, sir.
Yeah, you should start vitamin A by 6 months also, right?
Yes,
so whether the child was given, because vitamin A deficiency, vitamin D deficiency, measles, bronchopneumonia are going to be the complications of all these severe acute malnourished children. So when you say partially immunized, you should also write that child had 3 doses and 6 months of vitamin A was whether given or not given. Of course, measles was not given. You should particularly put that also. Child did not have measles vaccination at 9 months. That's why I say partially immunized. Okay?
Yes, sir. Family history. Father was 27 years old, whose education status is 10th grade, and he's a driver by occupation. And mother is 23 years old, and she's also 10th grade, and she's not going for any works. Developmental history. Gross motor milestones appropriate for age. Fine motor attained appropriate for age. In language milestones, at present child was 18 months of age, and he is not attained 8 to 10 meaningful words. So only language delay is present, no other development delay was present in the child.
Only child says only single word now.
2 to 3 words, sir, like.
For 1.5 years, you don't agree with that. It is good, normal.
I said not.
So even though the weight is not there, the other motor development seems to be good in this child, correct?
Yes, sir.
And child is able to utter 2 words, right?
Yes, sir.
Yeah, I'll be happier with the 2 words when the child is 1 year and 6 months only. I'm happy that.
Yes, sir.
We cannot completely strictly follow the textbook description of they should have 3 books, 3 languages, 3 words, something like that. No. So I don't say, how do you explain a language delay in a malnourished child? If you say there is a delay in language, how do you explain? Suppose you say a motor delay, you can explain. You say a fine motor delay, you can explain. But when you say language delay, how do you explain in a malnourished child, the child has got a delay in language? Very unlikely, right? So don't get caught into those kind of finer things. Okay. You said motor function, motor development is fine. Language also is fine. That's all, right?
Yes.
Suppose only isolated motor delay, what other underlying etiology will think of? Only motor delay. Other milestones are normal in a child with malnourished, undernourished.
Sir, since the child is malnourished, the bulk and power of the muscles were not adequate to support the baby's weight.
Okay. So which vitamin deficiency is associated with isolated motor delay? So rickets, vitamin D deficiency.
Very simple. Sir is asking vitamin D.
Yes, sir.
Yes. Okay.
Okay.
Diet history. Breastfeeding continued till 1 year of age. Initially 7 to 8 times per day up to 6 months of age. Then 3 to 4 times per day up to 1 year of life. Along with the complementary feeding, which was started from 6 months of age. No history of formula feeds given. History of giving commercially available packaged complementary feeds from 6 months to 9 months of age. Mother started giving diluted cow's milk with water in the ratio of 1:1 using feeding bottle, and from 8 months of age, homemade semi-solid food was started to the child.
What is the problem with the commercially available food? What is the problem with that? Why we are strongly not recommending all these milk powders and other things? What is the reason?
Sir, it suppresses the appetite of the child.
No. See, very simple reason is the protein given by the commercial food did not match with the growth of the child. What is the weight of the child?
Sir, at present 5.8.
5. How much fluid you give for a 5.8 per day?
Sir,
how much fluid per day you can give for a 5.8 gram child?
Sir, 580 ml.
580 is a maintenance. If there is no edema, I can go up to 120 ml also.
Yes,
But in such, don't go for holiday and cigar always. Holiday and cigar is for the only maintenance when the child is sick. So when the child is not sick, you should go with edema or without edema. The child is without edema, you can go up to even 120 ml per kg also.
Yes,
Suppose I say 600 to 700 ml per day. Okay, you are giving some milk powder in the form of lactogen or dexolac, something like that. What is the problem with the ml? For every 30 ml, you give 1 teaspoon powder, right?
Yes,
so 100 ml, you give 3 teaspoon. For 700 ml, you use 21 teaspoon of powder per day, correct?
Yes, sir.
So 100 gram of all this milk powder will give only 10 to 12 grams of protein only. When I say 100 gram, 20 teaspoon. That means 20 teaspoon, 10 to 12 gram. For a child with 7 kg or 5.8 kg at 1 year and other thing, to calculate the protein, it will be more. That means this milk powder, even though they take 700 ml milk with lactogen or lactose or something, they are not meeting with the proteins because the protein is only 10 to 12 grams per 100 gram powder for 20 teaspoon. This child needs 20 teaspoon. That means you cannot give more fluid. Child will go for pulmonary edema also. You cannot go more than 900 ml, 1000 ml also. You cannot go. That's why I always say that breast milk is always good. If the breast milk is over, you go for complementary feeding. Our semi-solid food should be in the form of homemade available. If you go for all these artificial products, you are not meeting with the calories and you are not meeting with the proteins. So you are not supposed to do that. In fact, I recommend almond milk because that gives 100 milk gives 3 grams of protein. If I need some 21 grams, 700 ml of almond milk will suffice. So number 1 is our feeding. Number 2, don't go for artificial powder feed. Go for our own milk product. Then go for this one. So I am not recommending almond milk. But what I am saying that instead of going for that, you can go for this. Otherwise, best thing, our Indian made home available semi-solid food after 6 months, continue with the breast milk is good enough, right? So that's why discourage the artificial milk powders. It will not meet out your required energy or protein. You have to dilute more. You have to give more fluid that will cause pulmonary edema to the children. Because all the milk powders, whatever be the company, 100 gram powder gives 10 to 12 grams of protein. That means 1 teaspoon of powder will give 0.5 gram of protein, which is not sufficient for the children. Okay?
Yes, sir.
Okay, right.
Now, how do you know about the adequacy of the breastfeeding? You said breastfeeding till 1 year, no?
Yes, sir.
So initially 7 to 8 times per day.
Yes, sir.
What's the duration of breastfeeding during that time, and how will you say child is getting adequate feeding during at that time?
Sir, initially up to 6 months, mother used to feed every second early, third early, sir. Child with adequate sleep in between.
What's the ideal duration of feeds you should give for a term baby or preterm baby? How long you have to feed a baby for getting adequate feed?
20 to 30 minutes.
Yeah, good. 20 to 30 minutes at least. Each breast 20 to 30 minutes. The alternate breast you have to give every time.
Yes,
If at the end of 6 months, SR say, no, what's the weight gain during at the end of 6 months of breastfeeding? That you don't know.
The birth weight should be doubled.
Yeah, okay.
How do you say that the baby has taken adequate breast milk? How do you say?
Child sleeps adequately in between the feeds and passes 7 to 8 times urine per day.
don't take the urinary output into consideration. You said the first word is correct. The child will have a sound sleep. That is fine, because urinary output always mislead you. Sometimes the child takes only 4 milk. They can have 10 to 12 times of urinary output when they are not taking hind milk also. So that means you cannot say the child is breastfed adequately. When I say adequate breastfeeding, it includes 4 milk and hind milk. It is not only the 4 milk. So urinary output, even though textbook writes, I don't agree with that, because most of the 4 milk babies who takes a lot of 4 milks every 1 hour or 2 hours, they pass 10 times, 12 times urine. That is not the correct clinical statement. So only the sleep, that is very important. Number 2, the weight gain every day is very important. Okay. Can you measure the breast milk?
Sir.
If any of you have done, any of you have measured the breast milk in your ward, any postgraduate, whether you have measured breast milk in your ward, I have done. How to do? Very simple. It is called test weighing. That is, you weigh the child first. The child is 3 kg. Give the breast milk for 30 minutes. Then immediately weigh the child. The 3 kg becomes 3 kg 30 grams. The 30 gram is nothing but 30 ml of mother's breast milk. This is an indirect way of measuring the breast milk, so that you should know whether the mother is secreting 400 ml or 500 ml or 600. How many PGs have done that? Please go and do it in your ward at least from tomorrow. When the mother is breastfeeding, weigh the child before feeding, weigh the child after feeding in the same weight machine. See the difference between pre-feeding and post-feeding. That difference is equal to the secretion of milk. Okay?
Yes, sir.
Right.
Diet history, just calculated according to pre-illness intake. The child had a calorie deficit of 500 kilocalories with a protein deficit of 3 grams. Socioeconomic status, the child is in a semi-paka house.
Go to the previous slide. Go to the previous slide. What is the expected protein you want in this child?
Sir?
It's a 1.5 year, no?
Yes, sir.
It's a 1.5 year old child. So you expect a weight of around 10.5 kg or 11 kg.
1 kg, sir, 11 kg.
What is the expected protein you want in this child? You should calculate either to the present weight or calculate to the expected weight. If you want to calculate the expected weight gain, it should be around 1.5 to 2 gram per kg.
Yes, sir.
So that means I expected a weight of 21 gram, not 17 gram protein. 20 grams at least minimum. It is not 17 gram is not adequate for a 1 year 6 month old child. So you should calculate in 2 ways, either for the expected weight or for the present weight. When I am calculating for the expected weight, I go by formula to 1.5 to 2 gram per kg. And I calculate for the present weight, I go by the formula 3 to 4 gram per kg of protein. So the expected protein should be around 21 kg and the calorie should be around this one. Your calorie also is a little bit less expected. 540, you calculated for the weight. You can, if there is no edema, you can increase the calories. You can say 600, 700 calories also, right? So the protein value is not correct. 17 gram is not correct. You should calculate for the expected weight or present weight. So take home message, 2 gram per kg for the expected, 4 gram per kg for the present weight. Okay?
Yes, sir.
Right.
For the normal BMR itself,
that means the child is very costly deficient in protein and calories, right?
Yes. For basal metabolic rate itself, you need 50% of the calorie. So only 50% of calorie, very difficult to live. Yeah, continue.
Socioeconomic status, child is in a semi-paka house, uses borewell for drinking and for household purposes. Child was given water without boiling, belongs to upper lower class according to modified Kupsami scale. Summary, a 1 year 6 month old male child, firstborn child out of non-consanguineously married parents. The child is a late preterm baby belonging to upper lower socioeconomic status according to modified Kupsami scale and was partially vaccinated. Presented with a history of fever and cough with a dietary deficit of 510 kilocalories and a protein deficit of 3 grams. The probable diagnosis being a lower respiratory tract infection with the malnutrition.
So not gaining adequate weight is not there.
Yes,
No,
sir.
no, he has not put it even in the history also. So you should put the adequate weight gain whether during the breastfeeding time or during the when you started introducing the complementary feeding. You should be keep on stressing those points when you are presenting a malnourished child whether there is adequate weight gain according to the mother. You can put the word according to the mother. Not necessary that you should measure. Not necessary that mother should be intellectual. Mothers knows my baby is gaining or not. Whether it's 30 gram or 40 gram, don't worry about it. You
Yes.
should put a word according to the mother. According to the mother feels the child has got. Now you tell me, where is the point the child went for malnutrition? Before
Sir,
6 months or after 6 months?
after 6 months.
Why you say after 6 months? Because you don't know the weight of baby after 6 months. The baby is born with 2 kg only. I will say the malnutrition would have started even by 3rd month or 4th month itself. The breast milk may not be sufficient in this child, may not be adequate, or improper feeding would have been there. That's why I say first 6 months, whether the mother is happy with the weight gain of the baby or not, that history should be there.
Mother noticed only
If you
after.
want to say that after 6 months, poor complementary feeding, because this child did not get hospitalized many times. So I won't accept that hospitalization is going to be the cause for the malnutrition in this child. So this child should be either the feeding should be the problem. The problem is in utero. Child is born with SGA baby, 2 kg. It is not 2.5 kg. The problem started in utero. Why in utero? Because mother is anemia. So it started with the in utero. It went for PROM. The child is a preterm. But you said breastfeeding is, and then you should put a history in the first 6 months whether child has get adequate weight gain in the first 6 months during the exclusive breastfeeding. Okay?
Yes, sir. General examination. Child was lethargic and not interested in surroundings. Recognizes his mother, and is tachypneic, febrile, pallor present. No pedal edema, no icterus, no sinuses, no clubbing, and no lymphadenopathy. His hydration status was normal. Is thin built and malnourished.
How did you
Vitals,
say pallor? What examination you have done?
the palms and soles were pale.
No, it's okay.
Sir,
Did you have the photo of the child?
no, sir.
You should take photo and put it in the presentation also. Because
sir.
from the photo, we can diagnose whether child has got rickets or something also. Suppose
Yes,
you
sir.
are missing some diagnosis or
Yes, sir.
right? Okay.
Yes, sure. Sir. Vitals, the child is febrile and his pulse rate is 118 per minute, which was regular in rhythm volume, and no radial or radiofemoral delay, and all pulses were felt well. Respiratory rate of 45 per minute, which is abdominal thoracic type. BP 90 per 50 mm of Hg in right upper limb in supine position, and his saturation is 98% in room air.
What is the relation between BP and malnourishment?
Sir, BP will be in lower sides.
Very good, very good. See, in malnourishment, sometimes many textbooks says sometimes child can even have microcardia. Even heart may be small because malnutrition affects each and every organ in the body. Sometimes these babies can have a mild hypotension also. Okay, very good, right.
Head-to-toe examination, head normal in shape and size, no frontal bursing, and the anterior frontal was closed. Hair is lustreless, and no areas of alopecia. No dysmorphic facial features. In eyes, pallor present, no icterus. Ears were normal. The oral cavity, lips and tongue normal. And neck, no lymphadenopathy. Chest normal in shape, no Harrison sulcus or no rachtic rosary. Abdomen normal in shape. Extremities, no edema, no hyperpigmentation. Nails pallor present, no clubbing or any other deformities. No spooning of nails. Spine normal. Genitalia normal. No perianal excoriation. Skin, the skin was dry. No hyperpigmentation. Skeletal system, no bony deformities. Anthropometry. Anthropometry. The weight of the child was 5.8 kg, which is 52% of the expected weight, which was 11 kg, which is less than third percentile. The child is severely underweight. Length for age is 70 centimeter. which is expected against 83 centimeter, comes under less than third centile. And child's weight for length is less than third centile. It comes under severe acute malnutrition and grade 3 protein energy malnutrition. And head circumference is 46 centimeter, which falls between 15th to 50th centile. Mid-arm circumference was 10.5 centimeter, which again comes under severe acute malnutrition.
No more use PEM. Okay.
Okay.
It was the oldest. When I was a student, it was a classification.
Okay,
Gomez classification, IAP classification, welcome classification. So many classifications were there when I was a PG. Now
Yes,
the
sir.
only classification, WHO classification, where you have to
Yes.
go by that, whether it's a SAM or MAM or something like that. So don't say PEM and other things. Some examiners may not like it also. It's our olden days, right? Okay.
Yes, sir. Yes.
If you put the graph,
Yes, sir.
yeah, show it.
So, length for age at 1 year 6 months, the child is 70 centimeter, comes under third percentile. This is the weight for age. The child's weight is 5.8 kg, which again less than third centile. This is head circumference of the child, which is 46 centimeter, lies between 50th to 50th centile. This is the weight for length, which comes under less than third percentile.
Can you explain what is this -3, -2, -1?
So these are the
Can you explain? What does it mean? The standard deviation, no, -3, -2, -1. What does
Sir,
it mean?
it is less than the mean value.
What is that value?
Z scores.
See, always -3 says it is less than 70% of the expected weight for height for that age, for that gender. -2 means less than 80% of the weight for height for that age, for that gender. -1 means less than 90% of the weight for height expected for that age and that gender. So you take it as 70% below, 80% below, 90% below. That's what the standard deviation, all this curve shows. So you are rightly said that the weight is 55% and the height is 83%. So it comes under like that. Okay. So -3, -2, -1 is equal to 70%, less than 80%, less than 90% for the expected weight for height for that age group for that gender, maybe male or female. Okay. So somebody will ask you, what is the Z score? What is the standard deviation? You have to say what is standard. Suppose if I don't have a curve, but still I can diagnose without curve. The child is less than 70%, I can put it under -3 standard deviation, even without the growth curve also. So all this line shows that -70%, -80%, -90%. Okay?
Yes, sir.
Okay, right.
Systemic examination, respiratory system, inspection, trachea is in midline, no chest wall
Do you
deformity.
know what is Levin's classification? Levin's classification. Let me ask you one question. Whether this is acute malnutrition or chronic malnutrition.
Stunting is there. So
yeah. See, the Levin classification is very simple, no? What he says, when the weight for age is less than -3, and the height for age is less than -3, and the weight for height is less than -3, it is chronic malnutrition of acute onset. The same classification says, when the weight for age is -3, and the height for age is -3, and the weight for height is normal. See, this is the difference. When the weight for height is normal, even though weight for age and height for age is -3, weight for height is normal, that is chronic malnutrition. But that you see in here, skeletal deformities or skeletal dysplasias you can see. You can see a circus buffoon, no? They are very short. The height, for them, the weight for height is good. Because for that height, that weight is good. But if you take age and other criteria, they are called buffoons. So this Levin's classification will tell you, if all the three goes for -3, that is acute on chronic malnutrition. If the first two is -3 and the weight for height is normal, it shows the chronicity, very difficult to treat. Fortunately, this child is here acute on chronic malnutrition because weight for age is -3, height for age is -3, weight for height also is -3, right?
Yes, sir.
Okay.
Respiratory system inspection. Trachea is in midline, no chest wall deformity, chest moves symmetrically during respiration, no retractions. Inspiratory findings are confirmed in palpation, and the percussion shows resonant in all lung fields. Auscultation, bilateral air entry equal, normal vesicular breath sounds here, and bilateral crepitations are here. Per abdomen, on inspection, normal shape, no distension, no all quadrants moves equally with respiration. Umbilicus is in midline, no superficial dilated veins, no scars, and genitals were normal. Palpation, not warm, not tender, no acromegaly. On auscultation, bowel sounds were here well. CVS, the S1 is to hear, and no murmur. Central nervous system, the child was lethargic, no cranial nerve defects. And motor system, the bulk was equal in both sides, which was the child is malnourished, and power 5/5 in all 4 limbs, and tone is normal. Reflexes 2+ in all 4 limbs, and spine and cranium normal.
This I cannot accept. Severe acute malnourished children is a chronic malnourished with acute on onset. How can you say the tone is normal in this child? There might be a definitely slightly reduced tone. How can you say the power is 5/5 in this child? Do you expect a 1.5-year-old child with a weight of 5.8 kg will have a normal tone and normal power? I think some assessment is wrong. This child cannot have power of 5/5. This child cannot have a tone of 5/5. There may be a reduced tone. Because you said no, bulk is not there. The child is so spoony. Then how do you expect a power and muscle in this? Okay? So be careful in this. Even if you don't know anything, you can tell to the examiner the power is slightly reduced. The tone is slightly reduced. Something like that you can say and get escape from the examiner. Rather than the power is 5/5. The tone is fantastic. No, you cannot say like that in this child. Right? Just imagine how a 5.8 kg child can have normal power and normal tone at 1.5 years. When you say the age is 1.5 years, cannot be, right?
Yes, sir.
Because hypotonia also is the future of one of the differential diagnoses. When you discuss acute flaccid paralysis, one of the differential diagnoses for AFP apart from your GPA or GP, all these conditions can have a reduced tone. So one of the, sometimes they may be so flaccid also. You cannot count. Suppose the you are talking about 1.5 years, I will accept. Your weight is 5.8. It is equal. What is the nutritional age for this child? Nutritional age. You say skeletal age, you say chronological age, you can say endocrine age. What is the nutritional age? Which child will be around 5.8 kg? It's a 4 to 5 month old child. Even though the child is 1.5 years, I will say the nutritional age for this child is around 5 months old, right? So I cannot say more than 6 months in this child based on the weight. So don't say that the tone and power is normal in this child. Cannot be. Okay?
Yes, sir.
Right.
Diagnosis: a case of severe acute malnutrition.
What is the diagnosis?
A case of severe acute malnutrition with anemia and a respiratory tract infection, which is pneumonia. The probable etiology being inadequate diet, improper complementary feeding, poverty, and repeated infections. Investigations: complete blood count with all indices, peripheral smear, serum electrolytes.
Go to the previous one. Go to the previous one. Go to the previous one. Previous slide. Why you want to include poverty in this? It's a recurrent hospitalization. Only one time child got hospitalized. This is the second time in 1.5 years. That is normal for any baby. How would you say recurrent hospitalization? Where is the recurrent infection in this year? So this child did not have any hospitalization or poverty. The problem in this child is anemia per se. We don't know the weight gain during the breastfeeding period. And of course, complementary feeding also is contributing to the malnutrition in this child. So the parallel breastfeeding inadequacy and the improper complementary feeding would have led the child to it. It is not due to recurrent infection. You cannot just like that put it like that. Where is the question of infection in this child? Tell me. You cannot say recurrent infection. I will say recurrent infection. What is the definition for recurrent infection in children? 2 hospitalization in 6 months or 3 hospitalization in 1 year. So you cannot say that it is due to infection. You cannot say that it is due to poverty also. Mother is bought something and giving something. And this is the first child. You cannot say poverty. This may be due to the Anemia per se, you should include anemia in this child. You said baby also is parallel. So anemia in this child, we don't know about breastfeeding proper history, and we don't know about maybe the inadequate complementary feeding, all contributing. And more importantly, the prematurity and the low birth weight baby is contributing to the malnutrition, not the poverty or the infections, right? Okay.
So how do you classify SAM according to this diagnosis? How do you classify SAM? Again, you can classify for treatment purpose.
Complicated.
Yeah,
and
this is
non-complicated.
good. This is complicated SAM.
Wait.
Okay, continue.
Investigations, complete blood count, peripheral smear, serum electrolytes.
No, sir was asking some question, no? Complications of SAM. Sir is asking.
Sir, complications of, sir.
Yeah. Sir is asking, no?
Sir, hypoglycemia, hypothermia, infections, electrolyte imbalance, dehydration,
Good.
Micronutrient deficiencies.
Anemia.
Yes, sir.
Anemia, micronutrient deficiency. Yes, good, good. Okay.
Yeah, continue.
On investigations,
This child has got pallor, no?
yes, sir.
What is the hemoglobin level?
Sir, 7.2.
Huh?
7.2, sir.
Okay. What treatment do you want to give for the child?
Sir, iron therapy.
When will you start iron therapy?
Sir, after
When you-
the initial stabilization period,
Okay,
after
good,
7 days.
good. Why you are not supposed to start iron earlier?
Sir, the metabolism are not ready for the iron therapy. The free radicals may damage the metabolism.
Any other apart from free radical?
The absorption of the enzymes.
See, when you give iron to the child, it will get converted into ferritin immediately.
Yes.
For the conversion of ferritin, you need lot of proteins and calories.
Yes.
This child is already suffering from protein and calories. And if you give iron, whatever protein and calorie the child is having, it will be utilized for the conversion of ferritin. It will not be utilized for the growth of the child.
Yes,
That's why, for the fear of this thing only, there are 2-3 reasons why I'm not supposed to start iron therapy during the stabilization period, only during the recovery period. When I give adequate protein, when I give adequate calorie, which is good enough for the child for growth, that is the time I will start the iron. Okay?
Yes, sir.
Right.
On investigations, renal function test, liver function test, chest X-ray, manto, and sepsis screening, urine analysis, and stool examination, and finally ultrasound abdomen and echocardiogram. Yes.
To know the serum protein level in this child,
The serum protein was normal in this child. 6.
but you are not typed, right?
Yes,
Okay,
sir.
okay, right, right. Okay.
Yes.
Can I ask you one question now?
Yes, sir.
This child is a severe acute malnourished child, correct?
Yes, sir.
Without any edema, without
Yes, sir. Without any edema.
hepatomegaly.
Yes, sir.
So it in olden terms we say it is marasmus, correct?
Yes, sir.
Why it is not Kwashiorkor? Let me ask this question. When both marasmus and Kwashiorkor, the etiology is only protein and energy, why some children are becoming Kwashiorkor? Why some children, more children are becoming marasmus?
Sir,
This is a common examination question.
In
Yes.
marasmus, there will be more calorie deficits. In Kwashiorkor, it is a
No. That's all olden theory. That is 1970s and 80s theory. When there is
hypoproteinemia.
calorie deficiency, marasmus will come. Whenever protein deficiency, that is olden theory. That is the
Hypoproteinemia.
newer theory.
Hypoproteinemia.
Why hypoproteinemia? See, 85% of the children are becoming marasmus. 15% of the children are becoming Kwashiorkor. Why? I'll tell you the reason. Okay. What is catabolism?
Yeah.
Catabolism is glycogenolysis, protein degradation, fatty acid oxidation, right?
Yes, sir.
Hello?
Yes, sir.
Okay. How these three happens? How these three happens? These three happens because of two important substances called insulin and insulin growth factor. So when insulin and insulin growth factor is adequate, all this catabolism conversion. Suppose glycogenolysis occurs, glucose is replaced by the peripheral tissues. Protein degradation occurs, protein is taken care by the liver and produces good proteins. Fatty acid oxidation occurs, brain takes for energy. So all these things will happen when there is insulin and insulin growth factor. When it is deficient or not there, nothing will happen. In that scenario, peripheral tissues will not utilize glucose, protein will not be utilized, so hypoproteinemia will come. Fatty acid will not take care of the brain, so more fat go and get deposited in the liver. That's why you get fatty liver in kwashiorkor and edema due to hypoproteinemia. So if you do a study of all these children about the presence of insulin and insulin growth factor, you can come to a conclusion. Those children who got less in this, they will go for hypoproteinemia and fatty liver. Those children who are adequate in that will go for marasmus. So the olden theory that energy will cause marasmus, protein will cause kwashiorkor is gone. It's not there. The newer theory is this. During the catabolism, these two substances plays an important role. Understood?
Yes, sir.
So after an exam, anybody asks you why some children goes for kwashiorkor, some children goes for marasmus. This is the answer.
Yes, sir.
Okay? When the insulin and insulin growth factor is not there, then what happens? Proteins will not be utilized, so hypoproteinemia. Fat will not be utilized, so it is deposits in liver and produces fat. That's a big, see, a single etiology not eating produces one puny child and one chubby child also. This is one of the classical clinical scenario, a single etiology causing two disease. One is the marasmus, other one is the kwashiorkor. Oh, understood?
Yes, sir.
Fortunately, 10 to 15% of the children will go for kwashiorkor, 85 to 90% will go for marasmus. Right? Okay?
Yes, sir.
So this fatty liver, no? Sir told about
Yes.
fatty liver.
Yes,
What's
sir.
the reason for fatty liver in kwashiorkor?
It's a beta lipoprotein.
The absence of beta lipoprotein is needed for the mobilization of triglycerides from the liver.
Yes, sir.
So the triglycerides are deposits in the liver because of lack of protein.
Yes, sir.
As sir said, no? Okay, continue.
Okay. Go.
Management.
How did you handle these children? No theory. Not necessary. The theory is not needed. How did you manage this children, this child? You did a stabilization first, no?
Yes, sir. Yes, sir.
What do you mean by stabilization? What is the time you need to stabilize a SAM child with complication? Time needed.
So initial 2 to 7 days initial
No,
stabilization.
48 hours to 72 hours. If 48 hours to 72 hours, you are not stabilizing the thing, you are not doing justice to the child. Right? So
Yes,
you
sir.
should stabilize by 48 to 72 hours. Right. Okay.
What is refeeding syndrome?
Sir, due to excessive feeding, there will be more glucose, which leads to increased insulin production, which leading to hypokalemia, hypophosphatemia.
Very good.
Do
you know the story, how it came? Do you know the story, how it came?
Sir,
I'll tell you the story in few minutes. During Second World War, most of the Japanese people know all Vietnamese are put into prison and they were put under starvation. So they were on prolonged starvation for a long time in the prison. All war criminals. One day the premier, the Japanese premier, he had a birthday. He said, let us feed all these war criminals into a lot of food. So they gave a lot of food for them on that particular day. After taking heavy food within 3 to 4 days, many soldiers died. So the investigation, why many soldiers died? Then they found that the person who is on prolonged starvation, when was given him more protein and more fat and something, then it causes what is called as some disturbance. What you said, hyperglycemia followed by hypokalemia, hypomagnesemia, hypophosphatemia, which causes muscular dysfunction that leads to cardiac muscular dysfunction, and they die because of cardiac failure and cardiac dysfunction. So it was really happened in the Second World War. Following that only the terminology, what is refeeding syndrome or nutrition recovery syndrome has come. Okay. Yeah, how did you treat this child? Your plan of management.
IV fluids and IV antibiotics for infections. Since the child is lethargic,
IV
sir,
what IV antibiotic you want to choose as per WHO?
ampicillin. First line like ampicillin.
What WHO say? Ampicillin and gentamicin. Very good. 50 mg per kg of ampicillin every 6 hourly followed by 7.5 mg per kg of gentamicin per day. Good. Your voice is not clear. Other PGs also can answer. Not he alone can. Others also can answer. Right.
Second line antibiotic, ceftaxime or ceftriaxone can be used.
No, I didn't ask it. Second line. Okay. It's a case of pneumonia, no?
Yes, sir.
Severe pneumonia or plain pneumonia?
It's a pneumonia, sir.
Pneumonia. Then why he got admitted in the hospital?
So since the child is lethargic and not taking feeds for the past 2 days.
Because of the nutritional factors, child got admitted. Because plain pneumonia need not need admission as per IMNC guideline.
Yes, sir.
Only severe pneumonia needs admission as per IMNC guideline. Okay.
Yes, sir.
Right. Now you have treated the child with pneumonia, right? Antibiotic. Leave it. Now
Yes,
go
sir.
to the nutrition.
For
What
nutrition,
is your plan?
sir,
What is your plan for this child?
in the initial stabilization period, we check for appetite. Sir, F75 was given.
Appetite test you do, no? How do you do appetite test?
Sir, ready to use therapeutic food.
Good.
Given. 35 ml per kg was given, sir. If the child
Okay.
if the child is able to finish 25 ml per kg.
Okay. No, I will teach you a simple rule of thumb.
Yes, sir.
You take 100 gram of kanji, ready to use therapeutic food.
Yes, sir.
Weight is equal to teaspoon. This child consumes 5 or 6 teaspoon of kanji. Fast this.
Yes, sir.
Take 5 teaspoon of kanji. Is failed in the examination. He cannot be F75. So the appetite test is to know whether the child is got or not. If your stabilization is perfect in 48 hours, the appetite will come. As per the WHO classification, appetite returns in 48 hours. It will start disappearing. So in this child, 5.8 almost most. Yeah. So these children, I think, appetite test is full now.
So not audible, sir.
Star line cut ஆயிடுச்சு.
So what's the criteria for discharge? When will you plan for discharge for the child?
Sir, appetite of the child is improving with if there's edema should be resolved, and the associated infection should be treated, and child should be vaccinated.
Okay, that is the criteria. What's the weight gain expected?
Sir is asking about the weight gain. Weight gain.
5 gram per kg per day, sir. For 3 consecutive days, 5 gram per kg per day should be gained.
5 to 10 gram per kg for 3 consecutive days. Right. Okay. So you are discharging the child. What will you tell the mother?
Sir, the dietary advice should be given, sir, and follow-up should be advised. Regular weight monitoring.
What dietary advice?
Sir?
What is more important? You should tell about mother the red flag signs.
Yes, sir. Warning signs should be.
What is red flag signs in this child? Yeah, what is the red flag signs in this child?
The child lethargy.
Refuse
of feeds.
Vomiting, hypothermia. Okay.
Yes,
all these things, no? These are all called red flag signs. Then the mother should be taught. Okay.
Yes, sir.
Okay. What is the basic criteria? What is NRC? NRC. I think you have in Shivaganga Medical College. I think Sendil Kumar and Kontri Andy should tell me whether NRC is there or not. What is NRC? Nutrition, Rehabilitation
Rehabilitation
Center,
Yes, sir. Nutrition.
which is otherwise called nutritional ward. NRC. I'm audible, no?
Yes, sir.
Sir.
Sir, in the 20
You say
minutes,
whether
one more case, sir.
or don't know. NRC.
Yes, sir. NRC.
NRC is there, no?
Yes, sir.
What are the functions of NRC?
Sir, advice
Admitting
regarding
the child, stabilizing the child, treating the child, diet advice. Mother is made to participate with our cook to learn about how to cook all these recipes. By the time mother is confident, then the child can be discharged from NRC. That is the basics of NRC, not only treatment. The
Yes,
mother should participate with the cook, she's cooking the milk, how she's cooking the kanji and other thing. She should learn and she should be confident to feed the child. Then you can discharge the child. That is the concept of NRC, right? Shivaganga has NRC, no? Yeah, right.
Sir, one more case, sir. Short 20 minutes, sir. 15 minutes.
Okay, okay. The next presenter can directly go to the positive finding and give the diagnosis.
Short, solungappa.
Positive finding. Complaint, positive finding, positive examinations and diagnosis.
Okay, sir. Good evening, sir. My case is a 2-year-old female child. Second one.
Your name?
Good evening, sir. My name is Uma Shanti, sir.
Okay.
My case is a 2-year-old female child. Second born child out of non-consanguineous marriage. Was brought by a mother whose reliability was good. Chief complaints of not gaining weight for past 2 months. Complaints of fever for past 7 days. Complaints of loose stools for past 6 days. Complaints of reduced urine output for past 1 day.
Okay.
History of presenting illness. Child was apparently normal 2 months. Mother noticed that the child was not gaining weight like the other children of same age group. Fever for past 1 week. Was
டாக்டர் கொஞ்சம் ஸ்கிரீனை மாத்துங்க, அந்த ஸ்லைடை மாத்தி விடுங்க.
Yes.
நீங்க பேசிட்டே இருங்க. சந்தோஷம், ஸ்கிரீனை மட்டும் ஷேரிங் மாத்தி விடுங்க. கண்டினியூ பண்ணுங்கப்பா, நீங்க ப்ரெசென்ட் பண்ணுங்க. டைம் ஷார்ட்டா இருக்கு. ப்ளீஸ் கண்டினியூ.
Sir, complaints of loose stools for past 6 days, sir. 6 to 7 episodes per day. It was watery yellow, large quantity, not stained with the blood or mucus, not foul spilling and frothy, does not stick to pan, not related to feed intake, sir. Now, history of reduced urinary output for past 1 day. Last passed the urine.
By saying this, excuse me,
Sir?
by describing this diarrhea, what sort of diarrhea you are dealing with?
Sir,
It is osmotic or secretory or infective?
Sir,
Secretory diarrhea. Very good. Okay, go on.
history of reduced urinary output for 1 day. Last passed 8 hours ago. No history of dysuria.
This diarrhea you can tell whether it's osmotic diarrhea or secretory diarrhea, small bowel diarrhea or large bowel diarrhea. Everything you have described anyway. Continue.
Okay, sir. Child taking breast milk, drinks water eagerly. No history of vomiting. History of pica present. No history of passing worms in the stool. No history of perianal excoriation. No history
Just give the positive history, ma. Just give the positive history.
Past history, sir. Expect from the loose stools and fever with reduced urinary output. There is no other past relevant history. Past history. History of treatment taken for current illness in the private hospital on OPD basis with ORS solution. History of hospitalization 1 year back for fever and cough in a private hospital, for which she was hospitalized for 3 days treated with IV fluids and IV antibiotics. History of acute diarrheal disease 4 episodes in the past at 5, 9, 14th and 18th month of age. Each lasted for 3 to 5 days and he was treated on OPD basis. Not on any medications and no history suggestive of any chronic illness. Antenatal history, except for mother was the baby was second gravida, sir. The interpregnancy gap was less, sir, only 11 months, and the mother was underweight and anemic, sir. The natal history is a preterm delivery due to premature rupture of membranes. Cause may be attributed to the underweight and anemia of the mother. Birth weight was 1.7 kg, delivered at Sivagam Medical College. Baby had a NICU admission, was an O2 support for 2 days, and then weaned off to room air. EBM was initiated on day 2 of life, and DPF was started on day 6 of life, sir. And baby was discharged after 9 days of NICU admission, sir. And there was no further follow-up of the baby, sir. Postnatal history, child was on breastfeeding from birth till at present.
1 minute. This child is 35 weeks gestation,
Yes, sir.
1.7 kg.
Yes, sir.
Why direct breastfeeding took 6 days to start? No other problem for the child. Child admitted only for preterm care. That means thermoregulation and feeding. Why EBM in the first up to 6 days, then only started direct breastfeed? Any child more than 34 weeks will have a coordination of sucking, rooting, and swallowing. Weight is also adequate 1.7 kg. If it is more than 1.8 kg, I may not admit in the ward also. In that scenario, why breastfeeding was late in this child? Direct breastfeeding from day 6. Why it was not started on day 1 of life?
Baby was an O2 support. Mother, as per the history, she told that baby was an O2 support, sir. So,
O2 support for 2 days. What for? What for?
Sir, for
What
distress,
for? Can you give me a diagnosis? Can you give me a diagnosis? Whether it's TTN or HMD or any other thing? Why one oxygen support on first 2 days of life? This again shows that we are afraid of this 1.7 kg baby and give unnecessary management also. So you should substantiate diagnosis when you are giving oxygen for 48 hours. What for you gave oxygen for 48 hours in this child?
for TTN, sir.
No evidence, no?
Yes, sir.
TTN needs only 6 hours or 12 hours, that's all. Okay, but please take all these points. Any child crossing 34 weeks should go for direct breastfeeding, whether the rooting, sucking, swallowing is fine. And you should also give oxygen only when there is a need. Mild distress, you cannot keep oxygen, abuse of oxygen for 48 hours cannot be permitted in preterm, unless and otherwise there is HMD or some other problem. Okay? Right. Okay, go to the next slide.
Postnatal history, child was on breastfeeding from birth till at present. Weaning was started from 7 months of life, and no proper weaning practices were followed, sir. Immunization history, the birth dose was vaccination was given, a BCG scar was present. Last vaccination at 45 days of life. Child was not properly immunized.
Okay. Why immunization was not practiced in this child?
Sir, actually this family belongs to a migratory population, sir. So they are not particularly staying in a same community, sir. They often belong to. They often go where they miss their vaccination, sir. They are unaware of the importance of vaccination, sir.
When you say permanent resident, when you say migratory population as per SPM definition, a mother who stays there for 6 months is a resident. A mother goes every month from one place to another is a migration. Anybody who says 6 months, they are called resident. There cannot be say migratory population. So maybe because of the weight, the VHN would have afraid of giving the vaccination in this child. So you should go for detailed history. I will not say that this is a migratory population. Maybe before delivery by 8 months, you would have been there, but 3 months. Any mother who stays for 5 to 6 months, I will say resident. I will not say migratory population. So the SPM definition says that up to 6 months, more than 6 months, somebody stays, they are not called migratory. So your history should be in depth, whether the weight is the criteria for not getting proper vaccination in this child. We have discussed in many meetings. Last week also I had a meeting in Calcutta, how to give vaccination for a extreme preterm and low preterm baby. It's an advisory board meeting in Calcutta I was attending. Where we can see that many field staffs, they are afraid to do vaccination till the baby reaches 2 kg. That is the reason. Maybe the child was not properly immunized. Okay.
Family history, non-consanguineous marriage, nuclear family, no history of
Leave
any
it,
problem.
leave it. Go to the next slide. Go to the next slide.
There was no gross motor delay, sir.
Okay.
There was no developmental delay in the social
Okay.
diet history.
So what is the diagnosis?
2-year-old female child, second order born child out of non-consanguineous marriage, late preterm vaginal delivery, belonging to low socio-economic status, according to modified Kupusamy scale. The mother was booked immunized pregnancy. Child with a partial vaccination was brought with the complaints of failure to gain weight, loose stools, and fever. The dietary deficit of 550 kilocalories and 4 gram protein. Probable diagnosis acute diarrheal disease with malnutrition.
Want diarrheal disease or recurrent diarrhea? What is the diagnosis you want to put?
Sir,
You
is
only
an
said that 4 times child had diarrheal episodes and got admitted. You
yes,
told
sir.
me, no? You in the history you are saying, no? 4 episodes of there, but not admitted. Not admitted.
Baby was not admitted, sir.
Not admitted. Okay, right. Malnutrition, right.
General physical examination. A child was alert, awake, recognizing mother, not interested in surroundings.
Fine. Go to the next slide. Next slide. Next.
You didn't mention about hydration status in this child.
Sir,
General examination. Hydration.
Sir,
I was asking whether child had no dehydration or moderate, some dehydration
some
or severe
dehydration,
dehydration.
sir.
Huh?
With some dehydration, sir.
Some dehydration. You are saying the child is eager to drink.
Eager to yes, sir.
Yeah, that means some dehydration. Okay, that you should mention in the general examination also.
Okay.
That's what Sir is asking, whether hydration status has been mentioned or not. Okay, we're talking about diarrhea, no? You should maintain hydration, whether it's some dehydration or no dehydration. Okay?
Okay, sir.
Okay.
How will you assess the hydration status in a chronically malnourished child like marasmic? Suppose this child is a marasmic child. How will you assess the dehydration? How will you assess the skin turgor? How will you interpret the skin turgor?
Depending upon the vitals, sir.
Okay.
Depending upon the vitals and capillary refilling time, sir.
Depending on that?
Okay.
Head to foot examination. Head a normal size, size and no frontal pausing. Anterior fountain was closed. Hair was lustreless hair, sparse hair, thin, easily pluckable, brown in color, and no areas of alopecia. Face was no dysmorphic features, and eyes was sunken eyes and no eye signs of vitamin A deficiency. Was paler present and no stress. Ears normal, no discharge. Oral cavity, lips and tongue were normal. No cheilitis, stomatitis, glossitis, oral ulcers, gum bleeds, oral rush or dental caries. Neck, no lymphadenopathy or engorged neck veins. Chest normal, no Harrison sulcus, no rickety rosary. Abdomen was normal. Extremities, no edema, no hyperpigmentation. Nails pallor was present and no clubbing deformities, no spooning of nails. Spine was normal. Genitalia was normal with no perianal excoriations. Skin was dry, scaly skin. No dermatosis and no hypo and hyperpigmentation. A skeletal system, no bony deformities and no injury marks, bruises or contusions. Anthropometry, the weight of the child was 7 kg, 58% of the expected weight, which falls around less than third centile and below the 3 standard deviation. Inference third degree wasting. Height for age was 76 centimeter, of 85% of expected, which again falls under third centile. Below the 3 standard deviation, indicating second degree stunting. Weight for height falls below third centile. SAM, severe acute malnutrition. Head circumference is around 46 centimeter. Centile of 15th to 50th centile. Mid-arm circumference was 11 centimeter, indicating severe acute malnutrition. Sir.
Do you know what is Shakir tape? Do you know what is Bangles test? All you know, no?
Yes, sir.
Yeah, examiners might ask you, what is Shakir tape? What is Bangle test? Have you seen Shakir tape?
Yes, sir.
Do you have Shakir tape with you? Do you have? Can you show me in the video? Do you have Shakir tape? I think all of you, when you go to the examination, kindly have Shakir tape with you.
Okay, sir.
You can get only through Amazon, not through anybody. It is not available in surgical companies. You get it from Amazon. Have one Shakir tape with you always. Some examiners will get impressed when you show all those things as a postgraduate. Not alone tape, Shakir tape also. Even though it is mainly for the grassroots level workers, but still some examiners are interested in asking Shakir tape also, right?
Okay, sir. It's a graph of the child indicating head circumference, which falls in the from 15th to 50th centile. So weight for age of the girl, weight is 7 kg, falling below third centile. Length for height, the height of the child was 76 centimeter, which again falls below the third centile.
Another 5 minutes only. Fast enough. Yeah.
Examination of abdomen. Shape
anything particular? Anything particular? Normal, no?
No, yes, sir.
Normal. Okay, go to the diagnosis.
Summary: a case of severe acute malnutrition according to classification, grade 3 according to IAP classification, acute diarrheal disease with some dehydration with moderate anemia. Etiology being nutritional due to faulty feeding practices and poor socioeconomic status.
Why do you say grade 3 IAP classification?
Weight for age 50. Sir, weight for age.
Why you say grade 3 IAP class?
Weight for age comes under 50 to 60%, sir.
That's why I'm saying, see, after 2005, before 2005, malnourishment are based on only weight. After 2005, malnourishment included height also. That's why this weight-based classifications has gone away. Now the weight and height-based classification has come into picture. Now IAP has got own growth chart with the weight, height, and head circumference also. So you can just say severe acute malnourishment. Don't go to grade 3 according to IAP classification. Again, the old model need not tell to the examiners.
Okay,
because that weight classification is gone as per the WHO criteria. Height has been included. Okay? Right.
Okay.
Again, you put moderate anemia. Is there any this thing for moderate anemia to say?
So, is there
IMNCA, we have got anemia, severe anemia. So what do you mean by moderate anemia? Why do you say moderate anemia? Why that adjective?
No failure signs was there, sir, and the child was palms and soles were pale.
Is there any textbook giving classification like that? Moderate anemia will not have edema, will not have congestive cardiac failure.
No, sir.
Based on the
clinical observation.
No. See, whenever you want to say mild anemia, moderate anemia, severe anemia, you should substantiate with the clinical finding. You should follow either one guideline or other guideline. If you take IMNCA and FIMNCA guideline, they say only severe anemia. There's no anemia. That's all. Classification is over. So don't put mild, moderate to severe, something like that. You say anemia. If needs blood transfusion, you put severe anemia. That's all. Okay? Right.
Okay. Investigations. I would like to
severe anemia you can explain. Moderate anemia you cannot explain. That's what I'm saying. Right?
Okay. Investigations, complete blood cell count with all indices, peripheral smear and reticulocyte count, total serum electrolytes, serum calcium, serum phosphorus.
What is the nutritional management in this child? You're given the diagnosis, leave alone the investigations. Okay, this is the severe acute malnourished child, again from the in utero, preterm baby, 1.7 kg, then feeding problem, then diarrhea problem, then immunization problem. All problems together has led to the child to the malnourished state, right? Now we are going to treat this child.
Yes, child with acute diarrhea.
Go to the treatment.
Some dehydration.
Yeah.
Some dehydration, sir. Some dehydration correction should be given, sir.
What correction?
30 ml for 30 ml per kg. 30 ml per kg.
No, you cannot correct like that. ORS, how we do?
Severe dehydration, you're telling. Just tell about some dehydration.
75
Do
75
you know
ml.
Rizomol?
Yes, sir. Osmolar.
What's the
Yeah,
sodium content
70
in
ml,
Resomol?
right.
What's the sodium content in Resomol?
40.
45. It has low sodium.
Good.
You can
Good,
prepare Resomol from normal standard ORS or
Yes, sir.
WHO
Double
ORS.
the
also you can-
dilution.
Yeah, you can prepare.
Just remember, ma, 45 sodium, 40 potassium, 70 chloride. This is the only solution. Chloride is overtaking the sodium. Okay?
Yes, sir.
40, 45, 70. Right? This is the only solution where chloride is more. Right? 50 to 100 ml every stool. That is the proper way of giving IMNC guideline. Okay. Then
After the correction of dehydration, check for an appetite test, sir. The child is taking the.
I will ask you one question. I will ask you one question. In this child, the sodium is 125, potassium is 2.5. Will you treat hypokalemia and hyponatremia, or you treat hypokalemia alone?
Hypokalemia alone, sir.
You won't treat hyponatremia, right?
Yes. Over.
You are right. Why you need not treat hyponatremia in severe acute malnourished child?
Because of.
See, already the sodium is all sitting inside the cell.
Service more.
It is not a real hyponatremia. Most of the sodium are inside the cell. So there is no need to treat mild hyponatremia in some child. If you treat hypokalemia, they become all right. Of course, the sodium goes below 120 or 110, then you may treat. Otherwise, there is no need to treat. That's why your Resomol 45 sodium and 50 potassium. You cannot imagine potassium is so near to the sodium. Right? So hyponatremia in SAM child need not be treated unless and otherwise sodium goes below 120. Otherwise, you need not treat. Okay?
Yes, sir.
Right.
I'll show you the Shaggy's tape. I have one with me.
Good.
Yes, sir.
Thank you, sir.
Okay, Ma, next. You finished?
Yes, sir.
What is the nutrition advice for this child? Nutrition advice. How do you proceed with the nutrition in this child?
F75, sir.
F75, F100, I understand it. 0.9 gram protein. Are you really practicing in each and every day? It is there in theory. It is there in textbooks. See, I will tell you, this F75 is only for 6 children. The child is bedridden, cannot take anything. Those situations you are starting with F75. The child is able to eat well. I won't go for F75. I will go for maybe 1.5 to 2 gram per kg of protein for the expected weight. So leave alone the F75 or F100. Let me tell you, please tell me what sort of diet you are going to advise for this child who has got here 4 to 5 episodes of diarrhea plus other problem. What is the advice you want to tell to the mother? You give me some of the recipes, some kanjis. What are all the kanjis you know? What are all the recipes you know to practice? Tell me. What is higher energy milk? What is CPP kanji? What is RBG kanji? Can you tell me all those things? Which one you are practicing in Shiva? Are you practicing CPP kanji? That is,
Yes, sir.
you are practicing CPP, no? Cereal pulse protein you are practicing?
Yes,
This
sir.
400 gram of ragi, 350 gram of wheat, 150 gram of Bengal gram, 100 gram of groundnut with jaggery.
Yes,
Can you give in this child? Can you give in this child? If I happen to be the nutritionist, I will not start CPP Kanji for this child because of the evidence of 4 episodes of diarrhea. So what diet do you want to go for?
Cereal based milk.
Is combination of rice with Bengal gram, 1:1 ratio. 1:1 ratio. Mother will come and say that whenever I give milk, child passes diarrhea, sir. But there is no evidence of lactose intolerance. In that situation, you should go for some semi-solid kanji in this child being too whole rice Bengal gram kanji, where 1 teaspoon of rice will give 0.4 gram of protein and 1 teaspoon of Bengal gram will give 0.4 gram of protein. So you give rice Bengal gram kanji based on the protein calculation. Of course, for calcium and phosphorus, you are not supposed to leave it. You can give milk also. Then and there, you can reduce your milk. Suppose a mother comes and says, my child takes 6 times milk and 6 times passes diarrhea. What I will do? I reduce the milk to 2 times. On remaining 4 times, I go for RBG kanji, rice Bengal gram. So that the output of stool will come down. And at the same time, I'm continuing the basic requirement of milk for this child also, morning and evening. So that's why we always say that after 6 months, when you introduce complementary feeding, try to introduce with the rice-based formula. Then you can go for the wheat-based, because we know gluten hypersensitivity is one of the problems you can have. So always goes for rice-based formula in this child. Okay, this child is almost 2 years, expected weight of 12 kg. He needs around 20 to 24 grams of protein. In that situation, I can go for, how will you give me a diet history? How are you going to reach 22 grams in this child? You will reach 22 grams. Tell me. Did you put the diet history for this child?
At least
so all the young postgraduates, I will tell you one. Now I will give you one simple technique how to go about. That's why I said a concept called nutritional age. In the first case presentation, the weight was 5.8 kg. The nutritional age is 6 months. In that situation, I will not give the idli or upma for that child. The initial 4 or 5 days, I will go only with milk and semi-solid based on the age. 6-month-old child. Even though the baby is 1.5 years, the weight is 6 kg, nutritional age. So 6 kg will take what? He will take milk and kanji. So my prescription is going to be milk and kanji for some time. See the acceptance of the child. Then I will upgrade to the upma, khichdi, idli or something, even though the age is 2 years. Similarly, in this child, I will go for the 22 grams more in favor of milk and kanji. And I'll see whether the child is accepting it. Then after 4 or 5 days, the child start accepting. Then I'll go for our own idli, upma, kanji, everything. You can go for it. So you can always cannot rush nutrition to the child. You should calculate the nutritional age for the child based on the weight. And if you think what is the baby who is having that weight and what he will take. So that is my, so a 5.8 kg child in the first child, can you go and give idli and dosa for this child? It's very difficult to consume also. In those situations, you should go for all the proteins, all the calories should be metered out from the either in the milk form or in the semi-solid form, in the form of kanji or other thing. Then you can advance to the further nutrition in this child. Okay, what are the other things you want to prescribe apart from diet? What is 1, 2, 3? 1 milligram, 2 milligram, 3 milligram. What is 1, 2, 3 for all SAM child?
3 for iron.
1
milligram is
1 folic acid.
Come on.
1 folic acid.
2 is zinc. 3 is iron. It's not iodine, folic acid. 1 milligram is folic acid. 1 is folic acid, 2 is zinc, and 3 is iron. That's why 1, 2, 3. Yeah, zinc and iron you should give for these children.
And twice the recommendation of the vitamins.
Vitamins also, yeah. So are asking about vitamin A, vitamin D, and other
Vitamin
things.
A, if the child is, for this child, 2 lakhs international units. For this child, 1 lakh international to be given, sir, because the weight of the child is less than 8 kg, sir.
Very good, very good. As per WHO, if the child, whatever be the age, if the weight is not more than 8 kg, you cannot give 2 lakhs. You should give 1 lakh vitamin A. Good. So how do you manage vitamin D? Suppose the child has got vitamin D deficiency. What is your plan of management? Suppose the child is vitamin D deficiency, no?
Yes, sir.
You go for starch therapy or go for daily therapy?
Daily therapy. Daily therapy.
daily therapy you want to go. Anything you can go, you see to the compliance of the child, that is very important. If the compliance is not good, I'll go for stars therapy in this child.
Yes, sir.
Right?
Yes, sir.
Okay. So you have to inform the child about the diet, then you have to inform the child about the growth and about the red flag signs when you discharge the child, go back home. When they come back, you should expect the how the child is gaining weight and other things also. Okay.
Yes, sir.
Yes, sir.
Suppose this child is less than 6 months
you
old.
should strongly advise about the immunization also. You cannot leave the immunization. That is very important. The child should be given all immunization. I say even apart from the government immunization, other immunization should be practiced. What are all the other optional immunization which are not available in the government but should be given to these children? What are the
Influenza.
other immunizations?
Influenza vaccine.
Influenza vaccine, very good.
J.
You say you went up to 2 years, no? What are the other vaccines? Typhoid conjugate vaccine. Yes. Government is not giving. Hepatitis A, government is not giving. Yes. Varicella, yes. Then, any other vaccines you want to give for these children? Any optional vaccine? Any optional vaccine apart from this varicella, hepatitis A?
For moms,
so this child is correct. This child is so far on government vaccination. No, suppose the child comes to you, sir, my area is full of mumps. My child is malnourished and immunosuppressed. Can you give the vaccine? Will you give?
Yes,
yes, sir.
What vaccine will you give? Mumps, there is no separate vaccine for mumps.
MMR.
MMR. So what is the time gap you will advise to the patient? Suppose they had MR at this minimum?
Minimum 6 months.
6 months. Minimum 6 months, you go for MMR vaccine. Sometimes the child is more prone to go for pneumonia. Maybe you should go for PCV 13 also. The higher strains you should give because government is giving only PCV 10. Sometimes you may go for 13 or 14. The higher 4 strains which is not given by the government should be also covered in these children to protect these children from succumbing to pneumonia or diet. This child is already. What are the top 5 killers in under 5 mortality? Top 5.
Pneumonia, diarrhea, anemia, malnutrition.
One is pneumonia, one is diarrhea. Anemia la kadiyaduma, summa irma. 5 killers. Pneumonia, diarrhea, apro malnutrition, 3 apro 3 M, measles. அஞ்சாவது எம் மலேரியா தமிழ்நாட்டுல கிடையாது, நார்த் இந்தியால. ஓகே, சோ pneumonia, diarrhea, malnutrition, measles and mumps, top 5 killers in under 5 mortality in our country. Okay, what is the IMR of Tamil Nadu now? 2020 SRS data. இதெல்லாம் சொல்லலைன்னா எக்ஸாம்ல ஃபெயில். What is IMR? 2020 SRS data. Tamil Nadu 13 per 1000. NMR 9 per 1000. Under 5 mortality 17 per 1000. Okay, wow. 17 is under 5, 13 is IMR, 9 is NMR, 2020 SRS data. இதெல்லாம் தெரியணும். நம்ம prevalence of SAM 6.4%. Stunting எவ்வளவு இருக்கு நாட்டுல? 45%. Wasting எவ்வளவு இருக்கு? இதெல்லாம் கேட்பான் எக்ஸாம்ல. Wasting எவ்வளவு, stunting எவ்வளவு எல்லாம் கேட்பான். அதெல்லாம் you should all tell and the examiners ask you. All the statistics you should know. இப்போ nutrition case present பண்ணும்போது we should talk more about statistics more than the clinical signs and symptoms.
Yes, sir.
Okay.
Yes, sir.
Sorry to bother you, sir. I think we are just coming. Can we?
I'm up. No, we correctly finished. Thiru.
Sir, 9:30 தான் சார். மக்கள் நிறைய நல்லா இருக்கு சார், ஆனா கொஞ்சம் மக்கள் டயர்ட் ஆயிடுவாங்க சார்.
ஆமா ஆமா ஆமா, நம்ம பம்பார்ட் பண்ணிட்டு இருக்கோம்.
Thank you, sir.
I think both the PGs have presented well from Sivagangai.
Good presentation, sir.
I think.
Sir, before we close, there was one question from one of the. Why only few children with malnutrition have less insulin and IGF levels? Any specific reasons?
What, sir? What, sir?
இல்ல கேட்டிருக்காங்க சார் chat boxல. Why only a few children with malnutrition have less insulin and IGF levels?
Less insulin, sir?
less insulin and IGF levels chat box.
No, there is no reason. See, that's why the incidence of kwashiorkor is very less. Out of 100%, we have found why some children are going for kwashiorkor. 20 years we could not find out the theory. அப்பெல்லாம் எக்ஸாம்ல கேட்கும்போது நம்ம என்ன சொன்னோம், எனர்ஜி கம்மியா இருந்தா மராஸ்மஸ், புரோட்டீன் கம்மியா இருந்தா kwashiorkor. So finally, when the biotechnology நிறைய improve ஆன உடனே, when they start examining the insulin and insulin growth factor in each and every children, they found out that in the 10 to 15% of the children, it is very low. That means all this fat and other thing is not being utilized. So they land up with kwashiorkor. Why these children are less with insulin and insulin growth factor, that we should analyze further. This is only pertaining to the nutrition. Why some children are succumb to kwashiorkor because of these substances. That's all newer revelations that has come now. Now we should go further and study why these children have less insulin, why these children has insulin growth factor. At present, இவ்வளவுதான். இது கம்மியா இருக்கிறதுனால kwashiorkor வருது, அவ்வளவுதான்.
Thank you, sir. Thank you, sir.
Right.
Sir, your concluding remarks, sir.
Concluding remarks, I think both the PGs have presented really well, and more importance should be given. See, when you are presenting a nutrition case in the complaint, one nutrition complaint should be there. Whether it is diarrhea or vomiting or pneumonia, you should add, even the mother did not tell, you tell, according to the mother, the child is not gaining weight comparing with the other peer group. These are all the 3 complaints, sir. So don't stop with respiratory tract infection. You give the nutrient. That means the examiners will come to know that you are going to present a nutrition case. Otherwise, he will take you to pneumonia or he will take you to cystic fibrosis. He will not discuss nutrition later. So any complaints you give, most of the cases admitted will not give nutrition complaint. They will admit it either for diarrhea or respiratory tract infection or measles, something. You find out that the child did not get. But you put your positive questions to the mother, asking, how is the weight of the child? Mother say, Amma sir, my child is not gaining weight. Then you put it in the complaint box. You add that complaint. Even the mother did not tell the complaint. They impress upon the examiners.
Yes, sir.
Thank you, sir. Sir Sivanandam, sir, your comments, sir.
Sir, both of them presented well, sir. Good presentation. And both has a different variety, 2 varieties of cases they have discussed. And I learned many things from Srinivasan sir also. For me also, it's good only. Thank you, sir.
Thank you,
Thank you,
Thank you, sir.
Thank you, sir.
Thank you, sir. Sir, any comments from your sir, academic coordinator? Sorry, Vishwakumar sir, before I go for Vishwakumar sir, your comments, sir.
ரொம்ப நாள் கழிச்சு ஒரு நியூட்ரிஷன்ல மாஸ்டர் கிளாஸ் மாதிரி எடுத்துட்டார் சார் வந்து இன்னைக்கு வந்து கேக்குறது இல்ல இப்ப வந்து அதான் ரொம்ப நாள் ஆச்சு இந்த மாதிரி கேட்டு கிளாஸ் கேட்டு நிறைய கத்துக்கிட்டோம் சார். தேங்க்யூ.
நேத்து நடத்த வேண்டியதை வந்து இன்னைக்கு மாத்தியாச்சு.
ஆமா, ரொம்ப நாள் ஆச்சு சார் கேட்டு. தேங்க்யூ சார்.
Sir was not available, so we want.
Thank you, sir.
Thank you very much, sir. Sir, Murugesh sir, to call for the.
Thank you. All the best, postgraduates. All the postgraduates, you did really well. You are learning a lot. Now you apply yourself and start learning also. All the best.
Sure, sir. Thank you, sir.
Ashok sir, thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir. Thank you very much, sir.
Thanks.